evening, good morning everybody. We'll start it off with a smile. And this is, can I have my slides up? So the topic is when to smile and when not to. So the whole question is an expensive machine, now it's about 6 crores. And can I do all refractive errors with smile? I mean, if I invest that kind of a money, do I still need an excimer laser? I mean, if I again have to buy an excimer laser, it's going to cost me a couple of crores more. So what is the smile capable of doing and when can we do it? And of course, smile has a lot of revenue, so I put that emoji up. I am a consultant for Carl Zeiss Meditech. No financial interest in this talk. So let us look at different scenarios for which we can do smile. Then I look at scenarios where we cannot do smile. So this is low myopia, 35-year-old male. You can just see simple myopia, minus 1.5 sphere. Best corrected 6.6. Now a lot of people say that you cannot do smile for low myopia and the results are not that good. It's better to do a PRK or LASIK. Now why is that? That is because with a very low myopia, your lenticule thickness is quite low. The minimal thickness you can keep the lenticule is 10 microns, which is normally what we keep. But if you have to just treat 1.5 sphere, then you will be about 20 microns. 20 plus 10 is 30 microns, which is a very thin sliver of tissue, which is difficult to dissect and remove, and you can get lenticule tears, you can get lenticule tags. But what this machine is capable of is that you can add tissue. So you can add up to 30 microns of tissue. So in these cases, we add 30 microns of tissue and then it becomes easy to do. And you also have to see that in the central thickness, the minimum is 50 microns between the superficial plane and deep plane. Otherwise, it reflects on the deeper plane when it's making the cut and you can get undulations and then poor quality of vision. So you can get excellent quality of vision with smile for low myopia, provided you know what you're doing, you increase the minimum thickness. And this is the difference map for that patient. You can see that the correction is beautifully centered and you have a good correction. We also published a paper on comparison of smile and PRK for low myopia, and we concluded that both techniques are effective for correction of low myopia. However, smile has superior quality of vision and patient satisfaction because of post-op comfort and lower induction of abrasions at 3 months. The spherical abrasion was lower. This is high myopic astigmatism, minus 10 with minus 1.75 cylinder, and corrected well, uncorrected vision 6.5. If you look at the maps, these are typical cases for smile. You can see the difference map. Centration is excellent, pre-op, post-op, and the difference maps. This is very high myopia. Can we treat very high myopia? Now, smile, you can treat myopia and myopic astigmatism. Now, commercially, you can only treat myopia and myopic astigmatism. Myopia up till 10 diopters, astigmatism up till 5 diopters, and the equivalent is up to 12 diopters. So that is what it is restricted. But we have an open research software because I am a consultant to Zeiss. I do global trials. So I will just share some data with you. This is a 24-year-old female with a pre-op refraction of minus 15 with minus 3.5 SIL. So any of you all see it, you will say, this is only for phakic IOLs. Okay. So we corrected it with smile, and you can see that that was a residual refraction. You had some amount, but uncorrected vision of 6-9 parts. I'll show you the maps again. So this is the pre-op map. You can see this. And this is the post-op map. You can see the very well centered large flattening which is there, and that's the difference map. You can see if you look at the difference in the thickness, it is almost 161 microns of tissue. We removed 161 microns of tissue. This patient is stable, doing well. So very high myopia, it is available. We're doing a very high myopia study, but this is something I wanted to share, that yes, you can do it in the future if you invest in the machine. Even higher myopia, this was a 31-year-old female, minus 19 with 5 cylinder. We did a 2-stage bioptics correction. Stage 1 with ICL, she had a residue of minus 1.5 with 3.75 cylinder. We did smile for the residual power, and then she had a good correction. These are her maps, good satisfaction with bioptics. We have published our results with bioptics with SMILE in the Journal of Emmetropia, and we find that it's a very good procedure. You can do it 2 to 3 weeks after the ICL implantation. What about high astigmatism? So some of them say that, okay, if you have a pure cylinder, high astigmatism, patient is not suitable for SMILE because it doesn't have a tracker, cyclotorsion, etc. This was a 33-year-old female, pre-op. You can see 0.25 with 4-cylinder, post-op refraction. She has got a very minor half a cylinder, uncorrected vision 6.5. So this is the pre-op map. You can see the high cylinder, and then this is the post-op. You can see that the cornea is very nice now. The cylinder has disappeared. You can see the bow tie here. This is the difference map. This is what is treated, the difference map. So you can treat high astigmatism, but again, you need to compensate manually. You can do a manual cyclotorsion compensation, and this is our paper. This was a landmark paper published in the GRS. We found that the mean cyclotorsion was 5.64 degrees, which is significant. For 10 degrees, you lose 30% of the correction. So if the average is 6, you lose about 15% of your correction. So you get under correction. So if you compensate for it, I'll show you how you do it. It's a safe and feasible technique for high astigmatism. So this is how you compensate for it. After suction, after you applanate, you mark it pre-op 0-180. You have the marks there. You can see that there's a rotation of about 15 degrees. You can hold the cone, bring it into the 0-180 before starting the treatment, and you get excellent corrections. What I've seen is the long-term stability for astigmatic corrections are actually better than LASIK. But the newer machine, the 800, has software for automatic cyclotorsion, which will be available. So with your IOL master, you take the iris image and it automatically compensates for cyclotorsion. So it's not a problem treating high astigmatism. What about mixed astigmatism? This is another question. Mixed astigmatism can be done only by an excimer laser. But we had the open software, so we treated cases, I think 11 eyes we treated with mixed astigmatism, and we have sent it to JRS for publication. I'm just showing you an example. This was a 28-year female, +1 minus 4.25 cylinder, and we did the treatment, and post-op she had an uncorrected vision of 6.5 minor cylinder, but she was not accepting. So this is the maps. This is the pre-op map, and this is the post-op. You can see that the cylinder is corrected very well. That's the difference map. Hyperopia, this is again a 21-year-old female. Hyperopia right now is not commercially available, but it should be available by the end of the year with the 800, VISUMAX 800. They are launching the VISUMAX 800 on Saturday here, and I'll be talking more about it. But this is a 21-year-old female. We were one of the global sites for the hyperopia trial, 8 centers all over the world. So this is an example from that. You can see that she has got a high hyperopia, 5.5 sphere, 0.75 cylinder, improving to 6.5. Post-op plano with a very small 0.25, uncorrected vision, best corrected 6/6. Okay, and you can see the video of how you can do hyperopia with SMILE. And you have a very large zone. It goes up to 8.8 millimeters, so you have to use a medium cone. It removes more tissue in the periphery and less tissue in the center. Center, it's only about 30 microns. You can see, so it makes a donut-shaped pattern, and so you can treat hyperopia. We have finished the trials. It's being sent for publication. You can see the donut-shaped pattern, and then you dissect it like you dissect for myopic SMILE and then remove it. I will not go through this for paucity of time, but this is the kind of a pattern for, you have the optical zone, which can be 6.3 to 6.7 millimeters. You have a 2 mm transition zone, and then you have a 90-degree lenticule side cut, 8.8 cap cut with 0.25 clearance, 120 micron cap thickness, 30 micron minimal thickness, and you can remove it through a 2 millimeter access incision. So this is the difference map for hyperopia. You can see that this is the pre-op. topography. This is the post-op. You can see the central steepening. You can see the beautiful centration. It's centered on the visual axis. This is the difference map. You can see the large zone. The corrections are more stable. The amount of induced aberrations are less than with LASIK. So that, but the kind of results are similar to hyperopic LASIK. What about presbyopia? Yes, you can do mini monovision with SMILE also, and it works very well with myopic SMILE. And the same, this is the pre and post-op whereas like for myopic SMILE. You can also do monovision with hyperopic SMILE for presbyopic patient. This is a 46-year-old female, and you can see we aimed for a residual myopia of 1.75, ended up with -2 sphere, very happy 6.6 and 5, right eye dominant. And these are the maps. You can see the hyperopic treatments with the central steepening. Both eyes difference. So when not, so now you know that SMILE can be used for most procedures in the future, maybe in a year or so. But when should you not smile? You need not frown, but when you should not smile. So we look at it. One is if you have ocular surface issues, if you have Bowman's membrane dystrophy, if you have recurrent epithelial erosions, then I would suggest that you do a surface ablation rather than going for a SMILE or LASIK. Moderate to severe dry eye, again avoid SMILE. In mild dry eye, SMILE probably is better than LASIK because the number of nerves, corneal nerves that you're going to cut, the regeneration of the corneal nerves also is better with SMILE. So SMILE may be a little better than LASIK if there is mild dry eye, but if moderate to severe dry eye, this is when you avoid, you can go in for a phakic IOL. Corneal scars, if they are significant central denser scars, avoid SMILE because it is a femto laser and you can have vertical breakthrough in superficial scars, and if the scar is quite dense, then it does not penetrate, then you will have difficulty in dissection. You may not be able to dissect and remove the lenticule. Sometimes you get very thin peripheral scars because of contact lens wearers, contact lens infections. If it's a very thin scar, the laser will still penetrate. I had a case which had a scar which was in the mid, just paracentral area, which was slightly deeper at about 140 microns. So what I did is we kind of designed the lenticule to include the scar, and then we were able to do the SMILE. That was a unique case, but it was not a very dense scar. Then irregular astigmatism, again you would not like to do SMILE either because of trauma, scars, corneal surgery, post-refractive surgery, form frustrate keratoconus, and these corneas probably you should look at topoling treatments and you would avoid SMILE. You cannot do topoling treatments. This is a very fraction of your refractive case, a very small, maybe like 0.2%. Then the other condition is if you have ocular higher order abrasions more than 600 microns, then corneal or ocular wavefront guided treatments are suitable. SMILE, you can have correction of spherical abrasion that is coming, it's known as high SMILE. We are looking at it. SMILE itself does not induce a lot of spherical abrasion as compared to LASIK because of you don't have the cosine effect, the sum of so you don't have a reduced ablation in the periphery like an excimer laser. So it induces less spherical abrasion, but you can also kind of adjust that with Malacara notations, and then you can adjust the amount of spherical abrasions, which may be useful for presbyopic treatments that would be coming, but you can't really do a wavefront guided treatment. So those patients who need wavefront guided treatments, then SMILE may not be ideal. But again, that's a very small percentage. So these are some of the reasons not to do SMILE. To conclude, SMILE can correct all kinds of refractive errors safely and effectively in the future. Right now, only for myopia and myopic astigmatism. Iris registration automated cyclotorsion will be available on the 800 and you can get better astigmatic outcomes. By next year it should be available. Wavefront guided SMILE may be possible in the future with a customized lenticule profile being worked on, but it's probably not in the short future. So these are my indications on when to SMILE and not to SMILE. Thank you very much for your attention.
Thanks, Ganesh, for that lovely talk and holding fort while I was not being allowed inside. So,
if there are any questions, then I can.
Yeah, one quick question and then, yeah. So I was wondering, like I bought my Smile machine like almost 5.5, 6 years back. And when I bought it, I was being told that HYPEROPIA should be available anytime now. And it's been almost 6 years.
Yeah,
and you've been doing the trials in Nepal, they've done, and everybody's reported excellent results. What's holding back HYPEROPIA? Because we've got almost everything else.
It has
now.
to get the CE approval. So the global results have been submitted to the CE, and it is on the verge of approval, and hopefully they are going to launch it by the end of this year.
And will it come to both the VisuMaxes?
No, it's not going to come on the 500, because on the 500 it takes more than 30 seconds with a higher risk of suction loss. With the 800, it's much faster. For MYOPIC Smile, it's just like 8 seconds. For HYPEROPIC, it would be within 15 seconds. So it would be available only on the VisuMax 800. Plus, on the VisuMax 800, you can correct for angle kappa, which you cannot do on the precisely on the 500. You can kind of center on the visual axis, but here you can exactly measure and compensate for the angle kappa. And for HYPEROPIA, a lot of the HYPEROPs have large angle kappa, and then if you don't treat it exactly on the visual axis, you can have a lot of induced aberrations like coma, which can drop your best corrected vision. So that's why they are not going to give it on the 500. It will be available on the 800. So you'll have to.
A lot of competition for VisuMax now. They're very good machines, all available now. Four new machines available, right?
Yeah. Ours was the first one of the 5 for the global trials, and now I think we have about 4 installed, and they're launching it on Saturday. So it should. We're looking forward to the 800. Thank you very much, Gaurav, for including in my